Thank you, sir, Rajiv sir and KSOs for this opportunity. Good morning to all and welcome to the dear freshers to the world of ocular motility. From a wonderful talk on pupils, visual pathway and pharmacotherapy, we come to ocular motility. So I should confess that this topic was a dreaded topic for me in my first year and very less read. So I hope at the end of this talk, you will become a little more interested into it. I'll just start with a case. This is a common condition that can come to our casualty or to our OP. This lady was a chronic diabetic who presented with acute diplopia. And you can just observe her eyes in the primary position and in the positions that have been seen. We'll come to the case at the end of the discussion. So my talk will be outlined along these headings. First, a step-by-step discussion on ocular motility, some basics that we should know, then a description of each of the third, fourth, sixth nerve palsies, and what not to miss in such a case. So always when you are looking into ocular motility, it's better to start with a Hirschberg test to get an idea about the ocular deviation. Then we go to the cover-uncover test to assess the primary and secondary deviation to confirm on a paralytic squint. When you are doing your examination, ask the patient to keep his head steady to report in case of any diplopia. The ocular motility should be examined in all the 9 diagnostic positions of gaze. After that, check the deductions or the uniocular motions, and finally end with a convergence and saccade examination. So in this picture, we see the 9 diagnostic positions of gaze: dextroversion, levoversion. In dextroversion, elevation and depression. In levoversion, elevation and depression. Then the primary position with elevation and depression. So coming to the basics, the eyeball acts as a globe which rotates along the 3 axes of fixed axis: the vertical, the horizontal, and the anteroposterior. So this picture will show us which are the main elevators and depressors in the adducted position of the globe, and which are the main elevators and depressors in the abducted position. So why is it that the obliques act more in the adducted and the recti in the abducted? So if you remember from the anatomy of last week, the insertion of the superior rectus is oblique. So once the globe abducts, the superior rectus gets the advantage, and it's the main elevator of the muscle of the globe in the abducted position. Similarly, the inferior rectus. In the case of the oblique muscles, from the trochlea, they have an insertion which is at 51 degrees to the visual axis. So once the globe adducts, adducts, the main elevator is the inferior oblique, and the main depressor is the superior oblique. Now coming to the muscles which help us look upwards, lateral position, superior and inferior, superior rectus and inferior rectus, adduction and abduction, lateral rectus and medial rectus, and in the medial position, upwards and downwards, we have the inferior oblique and superior oblique. So this chart gives us an idea about the primary, secondary, and tertiary actions. And you must remember the code of SIM, which indicates that all superiors, that is superior rector and oblique, are intorters, and RAD, which says that recti are adductors. So basically, this is what we have to remember. Now coming to the innervation, there is a time-tested code of LR6SO4 that shows that lateral rectus is innervated by abducent, superior oblique by the trochlea, and all the remaining by the oculomotor. So now we'll just observe this video. Observe the right eye of the patient. You can see that there is difficulty in adduction. There is difficulty in elevation and depression, while abduction is full. So just suggestive of a right third nerve palsy. So how does a third nerve palsy presents? Usually presents with an outward rotated eyeball. Pupil may or may not be involved. There can be ptosis, and there will be a loss of accommodation. Now observe the right eye of this patient. You can see that the eyeball is inturned, and on right gaze, there is a difficulty in abduction of the right eye, and left eye, the abduction is full, which is suggestive of a 6th nerve palsy. So you please observe the right eye of this patient. You can see that abduction is absent in the right eye. All the remaining movements are full, suggestive of a right 6th nerve palsy. Now observe the gazes in the right dextroversion and levoversion. We can see that both the eyes are restricted in abduction, which is suggestive of a bilateral sixth nerve palsy. Now this little girl, she came with an inturned eye, an uprolled eye. So the diagnosis in this case is a trochlear nerve palsy. So these patients, they usually present with a compensatory head tilt to the opposite side to avoid diplopia. Now, how do we diagnose a vertical diplopia? So the Park 3-step test helps us in this case. First, we have to understand which eye is hypertropic in the primary gaze. Is this hypertropia increasing on the right gaze or the left gaze? Now, is it worse on a right head tilt or on a left head tilt? So I've shown this chart previously. From these 8 muscles, which are the elevators and depressors, we have to rule out a single muscle. So I will explain the Park step based on a case of a right superior oblique palsy. First of all, in a right superior oblique palsy, first step of Park is hypertropia will be in the right eye. So it is due to a weakness of the depressors of the right eye, that is right superior oblique or right inferior rectus, or a weakness of the elevators of the left eye, that is left inferior oblique or left superior rectus. So we have screened out 4 muscles. The next one is the second step, does it increase on right gaze or left gaze? So in superior oblique palsy, it increases on left gaze. So we have screened out the next 2 muscles because in left gaze, it is a weakness of the left superior rectus or the right superior oblique. Coming to the third step, it is on head tilt. Does it increase on right head tilt or left head tilt? On right head tilt, we see the hypertropia increases. So if it has to increase on a right head tilt, it is due to the superior oblique palsy. Now, in any case of a cranial nerve involvement, be sure to examine all the cranial nerves plus including 3, 4, 6, and 5. Always check saccadic movements and rule out any aberrant regenerations. Now we will just observe the videos of some patients. This patient, you can see the right eye is ptotic. It appears outwards rotated. And on elevating the ptotic eye, he's looking to the right now, abduction is full. He's trying to look towards the left, adduction is restricted. On elevation and depression, all restricted. So this is a chronic diabetic, ischemic mononeuropathy case. Now we'll see a patient who presents with vertical diplopia. Not very obvious, there is a right hypertropia. On doing the cover-uncover on left gaze, you can see the refixating moment is increasing. So it is a right hypertropia increasing on left gaze. So the next step in the Park 3 step is you do a head tilt. On left head tilt, there is hardly any refixating movement. Now what will happen on a right head tilt? Just see if there is any refixating movement. You can see there is an obvious refixating moment. This is diagnostic of a right superior oblique palsy. Now observe this patient who came after an intracranial surgery with acute diplopia. On right gaze, movement is full. On left gaze, there is definite abduction. Elevation and depression, all are full. So this is a left sixth nerve palsy. Now coming to our first case, in the primary position, you can see the left eyeball is interned and on dextroversion movements are full, but on levoversion, there is a restriction of the left eye, suggestive of a left sixth nerve palsy. So I have just given you an idea. Try, do again, and do again. Success will be yours. Thank you so much.